Hello everyone, welcome to my new video. So, today I will talk with you all about a very important topic that we all should know and we all should have a basic idea as an optometrist. So, I'm talking about latent hypermetropia. So, this latent hypermetropia, understanding signs, symptoms, diagnosis, all we will discuss today. So, for that, I also made one presentation. For that, I have to share the screen. So, wait a while and let me share the screen. Okay. Till then, wait for a while. So I think my screen is visible to all of you, right? So we can start the presentation. So in this first slide, what we can see that here in this eye, the light rays are getting focused behind the retina. But after some time, the light rays are now getting focused on the retina. So what actually it is happening there that we have to discuss. Let me put the laser point. Yes. So here, this is the thing that we need to discuss. What happened actually there that made the light rays to get focused on the retina without placing the convex lens in front of the eye. So let's start. So this is the introduction. So here the latent hypermetropia is a condition where the eye has a hidden amount of hypermetropia that is not immediately apparent. So latent means it's hidden. So it's not apparent. You will not see in your normal refraction or dry refraction. Okay, so you have to find it out. So the prevalence of this latent hypermetropia in India is about 14.17%. It is more seen in patients who are less aged people, less than 30 years of age, okay, more prominent because there in that age range, the power of the eye muscles are very much high. Okay, so that is the reason. So this is today's objective that after completion of this presentation, you will know about the causes of latent hypermetropia. You will know about the symptoms of latent hypermetropia. You will know about how we detect it, and you will know about the management of latent hypermetropia. So let's start. So before that, I want to discuss with you all about the general brief discussion on anatomy of the eye. So this is the cross-sectional diagrammatic representation of the eye, where we know this very well that eye is composed of three main coats. If I come from outside to inside, outside it is sclera, then in between the middle it is having choroid that is forming the that is in between it is a uvea forming the choroid, ciliary body, and iris, and also the innermost layer is retina. So in the posterior chamber, it is filled up with vitreous humor. Anteriorly, it is formed up by aqueous humor. And here the iris is forming a hole shape. Here it is known as pupil that control the amount of light that enter to the eye. So here, the ciliary muscle is responsible for a specific thing that is known as accommodation. So with the help of accommodation, the crystalline lens can shape, change its shape to make the near object clearer to the eye. Whenever we see a distant object, then we don't need accommodation. But when we see a near object, then as the light rays from the near object are come enter to the eye in a diverging manner, so our eye need more refractive power to convert that diverging light rays into focus on the fovea. So for that purpose, accommodation plays a very vital role where because of the accommodation, lens change the shape and it increase the refractive index as well so that the light rays can get focused on the fovea very well in a normal eye. Okay. So now this is the normal eye where the light rays are getting focused on the fovea of the retina, right? But in case of hypermetropia, light rays are getting focused behind the retina. If I tell about the refractive error, there is three type of refractive error: myopia, hypermetropia, and astigmatism. In myopia, the light rays will get focused in front of the retina. In hypermetropia, the light rays will get focused behind the retina. And in astigmatism, there will be multiple focusing points. Like one focus will get focus, may get focus on the fovea, another get focus in front of the retina or behind the retina, or both focus can get form or place in front of the retina, or both focus can be seen behind the retina, depending on what is the curvature of the cornea. So that is the types of refractive errors. So today we will only focus on hypermetropia, and specifically we will focus on latent hypermetropia. Okay. So here this is the classification of hypermetropia, where total hypermetropia. What is total hypermetropia? That is the combination of latent hypermetropia and manifest hypermetropia. So the latent hypermetropia means the amount of hypermetropia that is corrected by the help of natural tone of ciliary muscle. That is latent hypermetropia. Manifest means that is not corrected by the natural tone of ciliary muscle. And manifest also having two types, facultative and absolute hypermetropia. Facultative means the amount of hypermetropia that can be corrected by pressurizing the accommodation of ciliary muscle. That is facultative hypermetropia. And absolute means even after pressurizing the ciliary muscle, the amount of hypermetropia that cannot get corrected, that is absolute hypermetropia. So this is the classification of hypermetropia. So what is latent hypermetropia? Suppose the person age is 15 years of age. He is having hypermetropia of +2 diopter of hypermetropia. So in 15 years of age, the ciliary muscle is so strong that it can overreact, or it can induce the accommodation to make the focus on the fovea that was previously focusing behind the retina. So because of that, and the person is having the normal vision as the light rays are getting focused on the retina, but for that he is using extra effort to make the light rays get focused on the retina. So that extra effort that is induced by the ciliary muscle in the form of accommodation lead to several symptoms that I will come in the later slides. So let's go to some mathematical calculation so that we can understand it very nice. Okay.
So now let's understand the total hypermetropia and latent hypermetropia. So total hypermetropia is equal to manifest hypermetropia plus latent hypermetropia. And this total hypermetropia means, manifest means the amount of hypermetropia that you got in your dry refraction value, and latent hypermetropia is the hidden power that you need to calculate or get after cycloplegic refraction, right? Now, manifest hypermetropia is two types, facultative hypermetropia and absolute hypermetropia. So, facultative hypermetropia means the amount of hypermetropia the patient can correct by giving pressure to his accommodation, that is facultative hypermetropia. So, the main difference between this facultative hypermetropia and latent hypermetropia is that latent hypermetropia is the natural tone of ciliary body, and because of the natural tone of the ciliary body, the amount of hypermetropia that is corrected by the help of the natural tone of ciliary body, that is latent. But above it, if the patient forces to see a object clearly, that is facultative hypermetropia, and the remaining hypermetropia that cannot even correct it even after giving the pressure to accommodation, that is absolute hypermetropia. Now let's take an example. Manifest is the dry diffraction value. You got the manifest value +3. Now, after the cycloplegic refraction, you got the value of total hypermetropia value, right? It is +5. So, what will be the latent hypermetropia? So, the latent hypermetropia will be total hypermetropia minus manifest hypermetropia. That means +5 -3 is equal to +2. That is the amount of latent hypermetropia. Now, during the dry refraction value, the patient managed to correct +1 diopter. That means facultative hypermetropia is +1. Okay. What you already got, the manifest value or the dry refraction value is +3. Now you got the facultative is +1. So what will be the absolute hypermetropia? So absolute hypermetropia will be +3 minus 1 is equal to +2. So this is the amount of hypermetropia that patient cannot correct even after giving the full pressure to his accommodation. So this is absolute hypermetropia, and so this is how it is whole calculated. Okay.
So here, now we got the idea about the mathematical calculation. So now let's go to the symptoms. What are those symptoms? Previously, what I told you, that the person was using his accommodation, that is the extra effort to make the light rays get focused on the retina that was previously focusing behind the retina. So, because of the extra effort that is induced by the ciliary muscle, the person will have frequent eye strain. This frequent eye strain just because of the extra effort that is given by the eye to make the light rays get focused on the fovea. With eye strain, there will be headache, eye ache, and also the child or the patient will have difficulty to focus for distance to near or near to distance, as well as they will give you the complaint that whenever they do a prolonged near activity, they feel blurring of vision. That is indicating you that the person might have latent hypermetropia. So to detect it, you cannot detect latent hypermetropia in dry refraction. So you have to go for the cycloplegic refraction to detect the latent hypermetropia. Okay. So how to diagnose it? This is the dry refraction going on. And in dry refraction, you only can detect the manifest hypermetropia. But to detect the latent hypermetropia, you have to instill the cycloplegic eye drop to the patient eye. And after putting the cycloplegic eye drop, as it takes some time to show its effect, so it is depend on which type of cycloplegic eye drop you are using. Let's assume you are using cyclopentolate. So cyclopentolate eye drop actually take 40 to 45 minutes to show its action. So after installation of the cyclopentolate eye drop and after 40 minutes, you did the refraction again. That is post-cycloplegic refraction and post-cycloplegic acceptance. Now, let's assume again the patient age is 15 years of age. The amount of hypermetropia now, previously the manifest hypermetropia you were getting is +3. Now in cycloplegic refraction, you are getting total hypermetropia value is +5. So what will be the amount of latent hypermetropia? That is +2. So if the that means total hypermetropia value is +5. Actually, I deducted the cyclopentolate drug value also, that we need to deduct a specific value that is 0.75. After deducting the working distance as well as cyclopentolate drug effect power, the ultimate total hypermetropia power we got is +5 times. Latent component +2, right? If the patient is a first time wearer, then and also if with the help of this total power that you are giving to the patient, and if he is or she is using or getting 6 by 6 vision, you should not give the full correction to the patient. Let me tell you why. Because once you give the full correction to the patient, she is a first time wearer, you given the full correction of +5 in the both eyes, the patient will never accept that power. So now what to do? Ultimately, you have to give the power to the patient. Otherwise, they can move to amblyopia condition. So here, it comes that you can give partial correction, or you can give if the patient is total hypermeter value is +5. Start your value from +3.5 or +4. So make it slightly undercorrected so that the patient will accept your power more easily. And call the patient in every 3 months and review the refraction, and then increase your power accordingly, so that the patient will not have that much symptomatic and they can accept the power very easily. But another thing, if the patient, even after giving the full correction, vision is not 6 by 6, you should not make the patient under correction, give the patient full correction. Because if the patient is not getting 6 by 6 vision, even after giving the full correction to the patient, then if you do undercorrect, then this also can lead to amblyopia, because you are not correcting the patient fully and she is not getting the full best corrected visual acuity 6 by 6. There is a target refraction. She is getting 6.9 or 6.9 partial. So at that time, you have to give the full correction to the patient. Now, the main concern, the question that you will ask me, that if I give the full correction to the patient, she will not accept. For that, what you can do? So here, simply, you can add homide eye drop twice a day for 15 days. Give the patient this homide eye drop twice a day for 15 days and give the full correction to the patient. Now this homide eye drop will relax the patient accommodation, and you given the full correction to the patient. The patient will accept the power very easily, and when the patient get adapted within this 15 days or 20 days, and the patient stop using this homide drop and eye drop, they can easily accept that power and adapt it to the power very easily. So this is how you should go in your workup. You have to look from patient point of view. You should not give the power, whatever you got the power, just give the power to the patient. No, it's not like that. Ultimately, the patient is your priority. And so that is why you have to look from the patient point of view that after giving the a huge amount of power, do they able to accept the power or not? That is why it is very important to evaluate the visual acuity. Okay. Treatment options. You can give the patient spectacle glasses, or you can give the patient contact lenses. And after, I told you one case where the patient is not getting 6 by 6 vision even after giving the full correction. That means the patient developed amblyopia. So in that case, vision therapy plays a very vital role. So you can suggest the patient for vision therapy as well. Now, another thing I want to tell you that in 15 years of age, the patient can have a very strong amount of accommodation, but that amount of accommodation will get reduced in 25 years of age. That means the amount of accommodation get reduced as the age progress. So if the patient having latent hypermetropia from childhood, it get apparent or manifest as the age gets progress. But if it diagnosed in the late stage, then the vision recovery is very poor. And also, if the patient age is more than 20 or 25, then it's very much hard to get the 6 by 6 vision if it is reduced earlier. And even after giving the vision therapy also, it's quite controversial. But from my point of view, it's very much hard to get the 6 by 6 vision with that also. But there is lots of advancement also came in vision therapy, so anyone can try that also. So first of all, some add-on point in bonus, right? And bonus points are definitely you should tell your patient to study in a very well light room, because it also influence the refractive error. So that is why it is very important. Okay. So that's all, friends. Thanks for watching, and please don't forget to like my video and subscribe to my channel. I hope this video helped you a lot in understanding about latent hypermetropia, and also it given you quite a bit idea that how to correct it. Okay. Thank you so much for your listening.